Let's talk Balma.
Welcome to this deep dive. We're here to cut through all the noise and focus on what really counts. Today, we're looking at some pretty big updates in how asthma is managed globally. These are changes that, well, they're crucial if you're living with asthma or just interested in it.
Yeah, it's great to be digging into these developments. They're really important.
Absolutely. And, right away, one of the huge shifts seems to be towards genuinely personalized asthma care. Like, forget the old way, the sort of one-size-fits-all thing.
Exactly.
Now, the focus is really on two things, isn't it? Controlling the immediate symptoms, obviously,
Yeah.
but also, just as vital, reducing those long-term risks.
Okay.
Okay, let's unpack this. So when we talk about these long-term goals now, what are we actually aiming for?
Well, fundamentally, the goal is for someone with asthma to live, a life that's not really restricted by their condition, as close to a normal life as we can get.
Right.
And practically, that means a few things. First, really good symptom control. So no persistent cough or shortness of breath or wheezing that stops you doing daily things or wakes you up at night.
Makes total sense. It's that day-to-day quality of life.
Yeah.
Okay, and the other big long-term goal?
The second key goal is minimizing future risks. So preventing those acute exacerbations, the really severe attacks that might mean A&E or even hospital stays. And we also want to prevent that slow, gradual decline in lung function that can happen if that underlying inflammation in the airways isn't managed properly.
Okay.
And of course, alongside that, we're always trying to use the lowest effective medication dose to keep side effects to a minimum.
Got it. So control today, but also protect the future. Now, there's a term floating around more lately, remission in asthma. Can you shed some light on that? What does it actually mean here?
Yeah, clinical remission or sometimes sustained remission while on treatment. It's a really interesting concept, kind of a step forward in how we think about managing asthma.
Okay.
It basically describes a state where a patient gets almost complete lasting control of their symptoms and the risks, but, and this is the crucial bit, while they're still taking their prescribed medication.
So it doesn't mean the asthma is just gone, like cured.
Exactly. No, and that's such a vital point. It is not a cure. Asthma is a chronic thing, right?
Right.
And even when someone feels absolutely fine, that underlying inflammation, it might still be lurking in the airways. Remission signifies, well, a period of really good stability, excellent control, but the disease itself hasn't vanished.
Why is making that distinction so important?
Well, because remission, people often associate it with things like cancer.
Sure.
And there's a real danger they might hear remission and think, great, my asthma's gone, and then stop their medication. We have to be crystal clear with patients, with families, that staying in this state of excellent control relies on sticking with the treatment. Symptoms could definitely come back if they stop or if they hit a major trigger.
That's a really critical clarification. Thanks. Are there any clues, any factors that might suggest someone's maybe more likely to achieve this kind of remission state?
There are some things we've seen in studies, yeah. For instance, kids who maybe had infrequent attacks, generally good lung function, they might be more likely.
Yeah.
On the flip side, things like having allergies or a strong family history of asthma, that seems to make it more likely the condition will persist. But look, this is still an active research area. We definitely need more data to really pin down who's more likely to get there.
Okay, so remission is kind of the aspirational goal. Now, you mentioned a process before, the personalized control-based asthma management cycle. How does that actually work day to day?
Right. It's this ongoing loop, really. 3 parts. Assess, adjust, and review. It always starts with a really thorough assessment of the patient as an individual.
Okay.
And we're looking at 2 main things in that assessment.
All right, what are those key areas?
First, we need to figure out their current level of symptom control. So asking really specific questions. How often are they coughing, wheezing, feeling breathless? How bad is it? Does it affect their sleep, their daily activities? And crucially, how often are they reaching for that reliever inhaler? We often use standardized questionnaires too, to get a more objective score for their symptoms.
Makes sense. And the second part of that assessment?
The second vital bit is looking at their risk factors for future trouble. Things that might make them more likely to have a bad attack or see their lung function drop over time.
Like what sort of things?
Well, their history, they had bad attacks before, especially ones needing hospital treatment. Is their FEV1 low? That's the measure of how much air you can blow out quickly, a key lung function test.
Right.
And of course, do they smoke? Or are they exposed to passive smoking? That's a big one.
Any other risk factors you check?
Yeah, absolutely. We also need to get a handle on their Adherence? Are they actually taking the treatment as prescribed consistently?
Adherence, always key.
Always. And then there's something that sounds simple but is just so important, their inhaler technique. If they're not using the device right, the best drug in the world won't get where it needs to go.
Okay, so that's a really comprehensive assessment. What happens next in the cycle?
Right. So after assessing, the next step is to adjust the management plan based on what we found. And this can involve tweaking a few different things. We might adjust their medicines, maybe change the dose, add something new, or even switch the type of inhaler device itself.
Okay, medication changes. What else gets adjusted?
We also really focus on those modifiable risk factors, the things the patient can actually change. Smoking is top of the list. They absolutely have to stop completely.
Non-negotiable.
Pretty much. We strongly encourage weight loss if they're overweight or obese. We look into specific triggers, things at home, at work, and try to find ways to reduce exposure. And we also think about psychological factors like anxiety or depression, because those can definitely impact asthma control.
And what about the non-drug strategies? How do they fit in alongside the meds during this adjust phase?
Oh, they're a huge part of the plan. Non-pharmacological strategies, right? Smoking cessation, like we said, that's got the strongest evidence, just evidence A. Regular physical activity, also incredibly beneficial, strong evidence, evidence A again. Weight loss for obesity, that's evidence B, still important. And breathing exercises, things like Buteyko, they can really help with symptoms and well-being, and that's got good evidence too, evidence A.
What about things like trying to clear out allergens at home? Dust mites, for example.
Yeah, that's a common question. For routine allergen avoidance, like trying to get rid of dust mites across the board for everyone with asthma, the evidence just isn't there to say it's generally effective.
Oh, interesting.
So it's not routinely recommended as a blanket strategy. Now, if someone has a confirmed allergy to something specific, like dust mites, then targeted measures might be helpful for that individual, but not as a general rule.
Okay, that's a useful clarification. And I assume patient education is absolutely vital in this adjust stage.
Oh, fundamental. Absolutely. We have to make sure people know how to use their inhalers properly because they're all different, right?
Yeah.
We need to teach them how to monitor their own symptoms, understand the written asthma action plan, what it means, when to step up treatment, when to get help. It's about empowering them, making them active partners.
Which sounds like it leads straight into shared decision-making. What does that actually look like?
Shared decision-making just means the treatment plan isn't something we, the doctors, just hand down. It's a dialogue.
Right.
We talk with the patient. What are their preferences, their priorities? What are their goals for treatment? We explain the options, the pros, the cons, and we work together to find the best plan for them, considering their life, their circumstances, and importantly, their health literacy, making sure they understand.
Making sure everyone's on the same page, understands the why. Okay. So we've assessed, we've adjusted. What's the last piece of this ongoing loop?
The final step is regular review, follow-up. Asthma isn't a set-it-and-forget-it's condition. We need regular appointments to check in, see how things are going with the current plan.
And what are you looking at during those review visits?
Basically, we reevaluate everything we assessed initially. How's their symptom control now? Are those risk factors still there, or have they changed? Any side effects from the meds?
Check adherence again. Inhaler technique.
Absolutely.
Yeah.
Are they sticking with the plan? Is their technique still good? And fundamentally, do we actually achieve the goals we set out together? And based on that review, we might decide, okay, things are great. Or, we need to loop back to the adjust step and make some more changes. It's that continuous cycle. Assess, adjust, review.
Got it. That cyclical approach makes so much sense for a chronic condition. Okay, let's shift gears now to something really significant. The updates in the actual drug treatments. What's the biggest news here?
Okay, this is perhaps the single biggest, most important change. It's a radical shift, actually. The guidelines now strongly recommend against using short-acting beta-2 agonists, SABAs, like salbutamol, or Ventolin alone, as the only as-needed treatment.
Wow. So just relying on the blue puffer when you get symptoms, that's out.
That's the strong recommendation, yes. For decades, that was standard practice, wasn't it? Yeah. But we now understand the risks much better. SABAs, they give quick relief, they open the airways temporarily, sure, but they do nothing for the underlying inflammation, which is the real driver of the problem. And worryingly, studies have linked relying only on SABAs, especially using them a lot, to a higher risk of severe attacks and even, tragically, asthma-related deaths. Here's where it gets really interesting.
That is a major shift. Okay, so if not just SABA alone, what's the new standard?
The clear recommendation now is that all asthma patients right from diagnosis need treatment that includes an inhaled corticosteroid and ICS.
Right.
Because ICS medications directly target that airway inflammation, they treat the underlying cause and reduce the risk of those severe attacks.
So ICS is now basically the cornerstone treatment for everyone.
Exactly. Some form of ICS is now seen as essential, and this has led to a new way of thinking about treatment steps, using two main pathways or tracks, especially for adults and adolescents, so 12 years and up.
Okay, track 1 and track 2, can you break those down for us?
Right. Track 1 is the preferred way to go now. In track 1, the reliever, the inhaler you use for quick symptom relief, is actually a combination inhaler. It contains a low dose of ICS plus a long-acting beta-2 agonist, a SABA, but one that works fast, like formoterol. So it's one inhaler, low dose ICS formoterol.
Okay, a combo inhaler for relief. How is it used in track 1?
Well, for people in the early steps, step 1 and 2, that's folks with milder, maybe intermittent asthma, they use this low-dose ICS formoterol inhaler only when they need it for symptoms. They don't take a separate daily preventer. This is often called the AIR-only strategy, anti-inflammatory reliever only. So if your asthma is mild, you basically treat the symptoms and the inflammation together just when you need it with that one inhaler.
So every time they need relief, they get a puff that opens the airways and delivers the anti-inflammatory.
Precisely. That's the key idea. Every time you reach for relief, you're also getting that dose of ICS to tackle the inflammation.
And what about people with more persistent or severe asthma in the higher steps, 3, 4, 5?
For them, in track 1, they use that same low-dose ICS formoterol inhaler, sometimes a medium dose in steps 4 and 5 as their regular daily maintenance treatment, and they use the exact same inhaler for extra relief if they get symptoms.
Okay.
This is called MART maintenance and reliever therapy, so the one inhaler does double duty, daily controller, and rescue inhaler. It simplifies things.
Why is this track 1, this ICS formoterol approach, preferred? What's the big advantage?
The huge advantage, backed by a lot of solid research, is that it significantly reduces the risk of severe exacerbations. We're talking like 60 to 64% fewer severe attacks compared to the old way of using a SABA reliever plus a separate daily ICS inhaler.
Wow, 64%. That's massive.
It's a really significant reduction. And importantly, day-to-day symptom control is generally just as good, maybe even slightly better. So it's a major win for safety.
That is compelling. Okay, that's track 1. What about track 2 then? When is that used?
So track 2 is the alternative route. We think about track 2 if track 1 isn't possible or suitable for some reason. Maybe that specific ICS formoterol inhaler isn't available, or the patient prefers not to use it, or maybe the MART concept seems a bit tricky for them.
And what's a reliever in track 2? Back to the SABA.
Yes, in track 2, the reliever is the standard SABA, like Ventolin, used as needed for symptoms. But, and this is absolutely critical, anyone on track 2 must also take regular daily maintenance therapy containing an ICS every single day, no exceptions.
Starting right from which step?
Starting right from step 2. So you can never be on just SABA alone in track 2. Step 2 would be daily low-dose ICS plus the SABA reliever.
Okay.
And then steps 3, 4, 5 would typically involve combination ICS-LABA inhalers at various doses for maintenance, still with that separate SABA reliever for symptoms.
So the key difference really boils down to, in track 1, you get ICS with every reliever puff, hitting the inflammation whenever symptoms flare. In track 2, the reliever itself doesn't have ICS, so you have to be diligent about taking your separate ICS controller every day to get that anti-inflammatory protection.
You've got it exactly. That guaranteed anti-inflammatory dose with every reliever use in track 1 is likely why it's better at preventing those bad attacks. Track 2 puts a lot more pressure on the patient remembering and sticking to that separate daily controller dose.
Okay, that distinction is really clear now. Now, we mentioned step 5 in both tracks. These are the people with tougher asthma, right?
Yes. Step 5 is for patients whose asthma isn't well controlled, even on high doses of standard controller meds, like high-dose ICS plus a LABA. We often call this severe asthma or sometimes difficult to treat asthma.
And how do you approach managing them? It sounds more complex.
It is. These patients really need referral to a specialist, like a respiratory physician or an allergist. We need to do a deeper dive, figure out the specific flavor of their asthma, what we call their phenotype.
Phenotype?
Yeah, basically trying to understand the main type of inflammation driving their asthma. Is it driven by cells called eosinophils? Is it primarily allergic, linked to IgE antibodies? We need specific tests to figure that out.
And once you know the phenotype,
then, based on that detailed picture, we start thinking about add-on therapies. That might mean adding another type of inhaler, like a LAMA, a long-acting muscarinic antagonist, or increasingly it means using these highly targeted biologic therapies. biologics.
Biologics, so like precision treatments.
Exactly. Think of them like smart bombs targeting very specific molecules in the inflammatory pathways that are overactive in certain types of severe asthma.
Can you give some examples? What do they target?
Sure. So there are anti-Ig drugs like omalizumab for severe allergic asthma. Then you've got treatments targeting eosinophils, anti-IL-5 or its receptor, drugs like mepolizumab, risankizumab, benralizumab. There's dupilumab, which hits the IL-4 receptor, affecting two key pathways. And a newer one, tezepelumab, targets TSLP, acting even earlier in the inflammation cascade. The choice totally depends on the patient's specific phenotype. It really is the pinnacle of personalized medicine in asthma right now.
Sounds incredibly targeted. Hopefully fewer broad side effects too. What about younger kids, say 6 to 11-year-olds?
Yeah.
Is it a similar approach?
Yeah, it's broadly similar. There's a stepwise approach for them too, and the absolute fundamental principle is the same. Treatment must include an ICS. The idea of just using SABA alone is out for them too.
Okay. So what are the options for that age group?
Well, in the early steps, it's typically regular daily low-dose ICS, with SABA used for relief when needed. But there's also the possibility now of using low-dose ICS formoterol just as a reliever, like that air-only strategy. So even for mild symptoms in kids, we're tackling inflammation early.
And is that MART system, the maintenance and reliever therapy with ICS formoterol, an option for them too?
Yes, MART using low-dose ICS formoterol is an option in the higher steps 3 and 4, for kids aged 6 to 11, just like for adults. And studies show it reduces exacerbations in this age group as well.
So really, that core message includes ICS, move away from SABA, only that applies across pretty much all age groups now.
Exactly right. If there's one message to take home, that's probably it. It's perhaps the most important change.
Okay, so if we were to quickly summarize the absolute key management points people need to remember for good asthma care today.
Right. First, don't forget those non-pharmacological strategies we talked about. They aren't optional extras, they're integral. Quick recap. Stop smoking. Avoid secondhand smoke, crucial. Get regular physical activity. Address obesity if it's an issue. And breathing exercise can help too. These lifestyle things really support the medication.
Definitely. What else is non-negotiable?
2 other points are just, well, extremely important. They can completely undermine treatment if they're not right. Inhaler technique and adherence.
Right. Technique and sticking with it.
We have to make sure patients use their inhalers correctly. Remember, different devices need different techniques. We need to teach it, check it, recheck it at every visit. It's amazing how often technique slips.
And adhere.
Yeah, committing to taking that regular maintenance treatment. It's so easy, especially when feeling well, to get a bit lax with the daily preventer. But that's when things can flare up again. We need to constantly stress why it's important and help find ways to make it easier to remember.
Okay. And one final crucial point for management.
The written asthma action plan. A clear, personalized plan written down.
What does it cover?
It tells the patient how to track their symptoms day to day, reminds them of their regular meds, crucially tells them when and how to increase treatment or use their reliever if things worsen, and very importantly, when they need to call for help or go to the doctor or hospital. The evidence is solid. Having and using an action plan really improves outcomes. It puts the patient in control.
Fantastic. Okay, that's a huge amount we've covered. If you had to boil it down for our listeners, maybe the 2 or 3 absolute most important messages to take away from all this.
Okay, 3 key takeaways, I think.
Yeah.
1, it's really farewell to the era of SABA only. Everyone with asthma needs treatment that includes an inhaled corticosteroid. Full stop. 2, treatment is much more personalized now. We really need to assess both current symptoms and future risks carefully to tailor the plan for each person.
Okay.
And 3, for most people, the preferred reliever strategy now involves that low-dose ICS formoterol combo inhaler track 1 because it offers the best protection against those serious attacks. So what does this all mean?
It means a much more proactive approach, right? Focus not just on feeling okay today, but really on long-term health and dramatically cutting the risk of severe asthma events. This has been incredibly clear. Thank you so much.
You're very welcome. Glad it was helpful. And actually, can I leave one final thought for people to mull over?
Please, absolutely.
With all these developments thinking about remission, these targeted biologics, understanding phenotypes better, where might this all lead for managing that?
That's a really powerful question. Moving beyond control to actual disease modification, halting progression, maybe even reversing some lung changes.
Exactly. Current treatments are already much better, especially the biologics. But the hope is, surely, that future therapies might make an even bigger, more fundamental long-term difference for those with the most severe forms of asthma.
It certainly makes watching future research in this area even more compelling. Thank you again. This was incredibly insightful.
My pleasure entirely.